Thank you to all the witnesses for being here today and helping the committee examine ways to both maintain quality but reduce costs as we're doing so. I care very deeply about this topic. I have a bill with Senator Bennett that I call the Medicare X Choice Act, and I want to talk about it a second. Dr. Fiedler asked you a question about it. Medicare X Choice Act would create a public option that would expand upon the successes of the Affordable Care Act, making affordable coverage available for families, individuals, and small businesses. It would direct CMS to devise an insurance policy that would cover the ACA essential benefits and offer that policy on the exchange for individuals and small businesses. An individual choosing to purchase that policy, if they qualified for the ACA subsidy, could apply that subsidy to bring down the cost of the premium, because the CMS devised policy would not need to cover a profit margin, fancy salaries, ads on TV, return to shareholders. It would likely be a very affordable option for people. It wouldn't force people to buy a government policy, but I think folks looking at the exchange would find it to be a very attractive option. The proposal would increase access to health care services in parts of our country that have historically faced challenges accessing care. Rural Virginia, rural America, where often there's inadequate options or choice on the exchanges. People, because CMS exists in every zip code in the country, it could be available on every exchange in the country. Somebody moving from Virginia to Oregon, not knowing whether the insurance company that insures them in Virginia even offers policies in Oregon, would need to worry about whether the Medicare X policy would be available, because Medicare already operates in every zip code. My colleagues and I have differing opinions about how to achieve the goal of broadened access and reduced costs, but I do think we have the common goal of doing those things. And that was why I was so gratified when the Urban Institute issued a report last year stating that, if implemented, the Medicare X Choice Act would reduce the number of uninsured people by about 1.1 million, save households about $10.9 billion a year, save the federal government $20.3 billion a year, and cut total spending on health care by $456 billion over a 10-year period. Increased access to care is not only good for individuals, it's good for communities. Dr. Fiedler, I'd like to ask you to speak about how the mechanics of Medicare X would both increase access to care and reduce health care spending over the long term.
Yes, thank you for the question. So this is something that Dr. Daphne alluded to in her testimony, but a striking feature of our healthcare system is that private insurers pay much higher prices for the same healthcare services than Medicare does. And that's a reflection of the fact that private insurers have to negotiate these prices with providers, and providers in many markets wield a lot of market power. Whereas Medicare is able to pay lower prices by setting prices administratively. So Medicare X would introduce a Medicare-like plan into the individual and small group markets, and because Medicare X would pay these lower prices, it would offer lower premiums than existing plans. It would probably, because of the lack of a profit margin and probably somewhat lower administrative costs, that would add to the premium reductions. So that's where the cost savings would come from. You also asked about access. In terms of access, there would be sort of two main effects to think about. One is that the lower premiums would cause some people who are uninsured today to take up coverage, which would improve their access to care. And then another is that the federal government would save a lot of money on the subsidies delivered to people who are currently insured. And the bill would then use some of those federal savings to enhance the subsidies available to people who buy coverage on the marketplace, and that would pull additional people into the market, into coverage, and improve access to care.
Thank you, Dr. Fiedler. We don't have the votes to do Medicare X yet, but I believe it's the next step forward that we started on a path with the Affordable Care Act. I don't think we should just go on a different path, but I think we should take the next step forward on the path we began. And I think offering a Medicare X policy on the exchanges and allowing people, as they shop, to do what Senator Braun said, to shop and try to find the most economical plans, I think that would be a good thing. Dr. Wright, I have a question for you, and then we will close the hearing. At a Budget Committee hearing last month, I asked Dr. Marilyn Moon about a New York Times article that caught my attention, and I heard Senator Whitehouse referring to it. The article was entitled, "A Huge Threat to the U.S. Budget Has Receded, and No One is Sure Why." And it was sharing the work of the CBO that between 2010 and 2020, Medicare costs were 9% lower than expected. The article was interesting in advancing different scenarios. I asked Dr. Moon if she had thoughts about why this happened, and she speculated two factors. One, that passage of the Affordable Care Act and an increase in people having insurance prior to joining Medicare might mean that people were a little bit healthier when they joined Medicare, and thus their expenses might have been lower, at least initially. And then she also pointed out that there is a demographic aging bubble of a lot of people turning 65 at once, baby boomers like me. I turned 65 in February. And younger seniors tend to be healthier than older seniors, so if you have a huge bubble of young seniors coming into Medicare, that can also affect costs. Given that CBO was responsible for the work that has led to this interesting phenomenon and speculation, can you talk about the factors that CBO took into consideration when doing the analysis and how those factors could potentially change over the next 10-year budget cycle?
Sure. There's a lot to unpack in that question. Let me start with the baby boomers aging into Medicare. That's a demographic phenomenon that's very well understood. It's very predictable, and it's baked into our demographic factors. So that is pretty straightforward to have a handle on. In terms of people having health insurance under age 65 because of the ACA and then aging into Medicare, that sounds plausible. We haven't dug into that and pinned down the size of that. The ACA did so many other things, big things in Medicare that phenomenon, my sense is relatively small. But one thing that I want to draw out is that the unexpected slowdown in Medicare spending actually started appearing well before 2014, when the coverage expansions went into effect. And so this is really a long-running slowdown phenomenon, and we know that we overestimated Part D spending. We know that Medicaid spending on long-term services and supports has turned downward. We're taking those factors into account when we project going forward. And I want to make a general point that we use the most recent historical evidence as our jumping off point. We look at our misses, we scrutinize those misses. When we come to understand our misses better, we explain to the world why we've updated our thinking. That showed up in the CMMI report in a big way. And our projections now, as always, we're trying to be in the middle of the distribution. It's likely to be too high as too low. The future is always uncertain, but we're trying to take on what we've learned and really dig into the phenomenon that Dr. Moon highlighted.
Well, great. Well, thank you, Dr. White. The fact that the CBO manages to make Democrats happy or unhappy and Republicans happy or unhappy. You know, I've railed at some CBO studies and been entirely comforted by others, and everyone around this table feels the same way. I think you're approaching the work that you do in this space with intellectual and integrity and an attempt to be even-handed, and I appreciate that. And I do think it's important. I applaud analyzing your misses, because when you miss something, going back and trying to understand why gives you the ability to calibrate and then, hopefully do a better job. I think the Samuel Beckett line is, ever tried, ever failed, no matter, try again, fail better. And so it sounds like that's the method that you follow. The hearing is now concluded. I want to thank the witnesses for appearing before the committee. Your written statements fully will be included in the record. Without objection, I submit statements for the record from Millbank Memorial Fund, the Rhode Island Quality Institute, the National Association of Accountable Care Organizations, from Professor David Cutler and Nikhil Sani, and a preprint publication in Health Affairs titled, quote, "Active Steps to Reduce Administrative Spending, Associated Financial Transactions in U.S. Healthcare." As information for all senators, questions for the record are due by noon tomorrow, with signed hard copies delivered to the committee clerk in Dirksen 624. Email copies will also be accepted. We'll ask witnesses if there are questions for the record that are submitted to respond to those questions within 7 days of receipt. With no further business before the committee, this hearing is adjourned.